Good afternoon, everyone. Myself, Dr. Divya Rattan, postgraduate student of Sri Guru Ramdas Institute of Dental Sciences and Research, Sri Amritsar. I'll be presenting a video to explain the lab procedure that is required for the management of bilateral undercut tuberosity case. Unilateral or bilateral undercut on the buccal aspect of the maxillary tuberosities are frequently encountered, and this may complicate the fabrication of complete maxillary denture. So, the management in this situation include alteration of the denture bearing area, adaptation of the denture base, careful planning of the path of insertion, and use of resilient soft lining material. So, a healthy 60-year-old female patient reported to the Department of Prosthodontic and Crown and Bridge with the chief complaint of replacement of missing teeth. She was edentulous for about a year, and on examination, it was concluded that the maxillary tuberosities were moderately enlarged and bulbous. So, decision was made to fabricate a complete denture with flexible flanges in the undercut region using resilient silicone lining material. But there are several problems with the soft liner. The more serious problem with the soft liner is the failure of adhesion between the soft liner and the denture base material. So for this reason, I have used glass fiber at the junction of soft liner and denture base material. So for this case, all the clinical steps were done in a conventional manner. That is, primary impression was made using impression compound. Then custom trays with spacer were constructed. For upper, I have used a silicone putty material for border molding, that is a single step border molding technique because of the undercut that were present. And for the lower, I have done a border molding in a conventional manner using green stick compound. For upper, the wash impression was made using lime body, and for lower, the wash impression was made using the zinc oxide eugenol impression paste. Then jaw relations were recorded and the casts were mounted on articulator. Teeth arrangement was done in a conventional manner and it was tried in the patient's mouth. So after trial, the flasking and dewaxing was done in a conventional manner. This is the armamentarium that I have used for the fabrication of flexible denture flanges. As you can see, the undercut area, which was found in bilaterally opposing tuberosity and the anterior labial region. Then the master cast was lubricated with separating medium and the undercut area was filled with modeling wax. So this wax will act as a spacer which will be later on replaced with soft liner material, that is Moloplast B silicone soft lining material. After the undercut areas were filled with wax, trial packing of the denture was done. For that, I have adapted a cellophane sheet or a separating sheet between the two portions of the flask. And then the flask was placed under pressure to remove the excess acrylic. The flask was opened and the flash was trimmed. Then the separating film, which was present between the two portions of the flask, was removed. The wax spacer that was adapted on the master cast was also removed. And the glass fiber which will be used to improve the bond strength is first pre-impregnated with monomer. This glass fiber is then adapted over the edges of the acrylic, that is at the junction of the acrylic and the soft liner using a brush. The soft liner adhesive is then applied over the edges of the acrylic and let it dry for 90 minutes. Mologlass B soft liner was applied with a spatula to all undercut areas of the cast. Then final packing of the denture was done and kept under pressure. So this method allows the flange of a maxillary complete denture to accurately duplicate the shape and dimensions of the vestibular space adjacent to an undercut, thereby ensuring maximal border seal and aiding retention of the denture. Both clinical and laboratory procedures fall easily within the scope of general prosthetic practice and no special equipment is needed.